Good morning, everybody. We're going to get started. Very happy to have Dr. Jing Wang from the Division of Pulmonary and Sleep Medicine. So Dr. Wang received her medical degree from Stony Brook School of Medicine and completed her medicine residency and pulmonary and critical care fellowship at Columbia before doing her sleep medicine fellowship at NYU. And currently she is the medical director of the Mount Sinai Uptown Sleep Lab. So I'm hoping she'll be able to answer some of the mysteries in the black box of
some
sleep
of that
medicine.
clarifications in there.
So thank you for coming.
Thank you for having me. Good morning, everyone.
Good morning.
It's like end of the year. Is this the last talk of the year?
Yeah.
Woo! Well, hopefully it's ending on a good note. Okay, so I was really excited when Dr. Pfeiffer or Kenny emailed me asking for a talk on sleep, and I literally said OSA is my favorite topic to talk about. So hopefully you guys will enjoy what I have to say. I had a lot of fun putting this together, and I tried to come up with this catchy name, but I don't know how catchy it is. So some of the old things and some of the new things that are going on in the field of sleep apnea. No disclosures. So this is just to start off, I put a slide in here, like a bird's eye view of OSA across the globe. Obviously, we're still missing a lot of data from areas such as Africa, Southeast Asia. Most of the data in terms of epidemiology of OSA really comes from North America, certain areas, countries in Europe. In terms of Asia, it's really the biggest studies are coming out of Hong Kong, Taiwan, and then there's a big cohort in Australia. But as you can see, there's OSA that exists everywhere to varying percentages for a variety of factors, which I will go through. Okay, so we all sort of know OSA as, or sleep apnea. For the purposes of this talk, I'll sort of use OSA and sleep apnea interchangeably. I left out the central sleep apnea part of it because that's really a whole many talks on its own. But basically OSA, we think of that as being characterized by repetitive cycles of airway narrowing and or collapse that results in either apneas, which when the airways totally collapse, or hypopneas, which is when the airways partially collapse, in the presence of ongoing effort. That defines the obstructive part of it, and that leads to arousals from sleep as well as hypoxemia. The prevalence, again, depending on which paper you're reading, which cohort you're looking at, on average, at least 25% between the ages of 30 to 70, and then the traditional risk factors, you'll see a lot of them are familiar here. They are seen on the Stop Bang questionnaire. So obesity, large neck circumference, gender. Males really have a higher prevalence of OSA than females in the premenopausal age range, and then there are certain anatomical features. For instance, in children, tonsillar and adenoid hypertrophy is a big risk factor, as well as certain craniofacial abnormalities. So just gonna depart from that for 1 second and talk about the concept of the P-crit, which is, I think, really helpful in understanding what causes upper airway collapse. I'm gonna use my mouse here. So the figure A here is basically a model of the upper airway, broken up into 3 segments. So we have an upstream segment that represents the nasal passages, and this is fixed, so there's no collapsibility here. There is the middle collapsible segment, which is the pathologic area that's involved in OSA, and then there's a downstream, another fixed segment that's basically the trachea leading to the lungs, and this again is non-collapsible. So each of these segments has their own individual pressure, so the PUS is the upstream pressure, PUDS is the downstream pressure, as well as their associated resistances. And the P-crit really is that positive external pressure that is needed to create airway collapse. So then you have the 3 scenarios down in the middle portion here. When you have scenario D, the P upstream pressure is greater than downstream pressure, and the P-crit is really the lowest, so the airway remains patent. Now, if you have a situation where the P-crit is greater than the upstream pressure, then basically you have airway collapse, right? And there's no flow. And then when you have situation C, which is really what we think is leads to the phenomenon that we see both clinically as well as in the sleep studies in OSA is this variable collapse. We call that flow limitation. So basically that's a state when the P upstream pressure is greater than the P crit, which is greater than the downstream pressure. And this leads to a state where on inspiration there is limitation to flow and the airway can actually go from cycle from being collapsed to open depending on other factors. So, and this was like a concept that originally, I think people started looking at it maybe in the 1980s. And since then, there's been a lot of, it's been used mostly on a research sort of basis, but I think it does help us understand sort of the underlying pathophysiology of OSA. So people have looked at or tried to measure P crit in patients with sleep apnea and without sleep apnea, and they generally find that patients with OSA have a higher or more positive P crit, and normal is really that this P crit is really negative, really in the negative range, and these people don't have signs of upper airway collapse in sleep. There's also a spectrum of P crit that sort of coincides with the spectrum of the disease states that we can see in OSA. So normals, again, the pressure is negative. In snores, it may be a little bit still negative, but a little less negative. In this upper airway resistance syndrome, which is sort of come and gone from the literature, it's sort of close to zero, / sometimes positive, and then going into obstructive hypopneas and finally apneas, you see a progressively increase or rise in the P crit. So I think with that framework, then it helps us to really think about what are the various clinical factors that we can look for in assessing someone for risk for OSA. So I divided this into two sections. So there's anatomical factors, which I already sort of touched on, but this has been sort of systematically defined. There's smaller mandibular size, actually higher cheekbones, a lower hyoid position. Those are all anatomical factors that are associated with increased risk of OSA. This is particularly relevant if you read literature from Asia, Southeast Asia, where a lot of those patients do have that sort of type of facial anatomy, and the incidence, and without being overweight, and the incidence of sleep apnea in those patients is actually similar to, if not more than, what we find here with the general U.S. population. Similarly, the decreased sort of velopharyngeal area also increases the risk of OSA. Tonsillar hypertrophy, essentially anything that's taking up space in the posterior sort of throat back of the airway can potentially contribute to increase in that P crit. So I see this a lot in obese patients. Increased fat deposition around the pharynx can again narrow the airway. If there's a lot of abdominal obesity, that can actually lower lung volumes because your FRC resting is higher, and that actually reduces the caudal traction, so that downstream part of the airway, and that can lead to a reduction or elevation in the P crit, or less protection against P crit being higher than the downstream pressure. And then there are also neuromuscular or neurohormonal factors. So this is really interesting and still, unfortunately, still sort of being elucidated as we speak. But something we do, very clearly see, there is certainly a difference in the neuromuscular tone between REM and non-REM. So REM is really characterized by atonia, except for your diaphragm, your heart, etc. So you lose all of your accessory muscles, the tongue, all of the essentially skeletal muscles becoming tonic, and REM is classically when we see OSA being either the most severe or desaturations being the most severe. So there's also a gender difference, and this is also not really well described, but I think in the past maybe 15 or longer years, there have been small studies describing how women have a different or maybe why women are more protected from OSA compared to males, at least in the menopausal ages, and we think that may be related to sort of differing
abilities in terms of neuromuscular compensation that occurs only during non-REM sleep. Because what we do know is that women tend to have more REM isolated sleep apnea. And this, we think, or papers describe, may be mediated by various sort of inflammatory markers. Leptin is a big thing. And then there's the chemical and sort of mechanical reflexes. So we know that hypercapnia is a big stimulus for upper airway neuromuscular activity. So that actually decreases the peak RIT. And so an individual's sort of pre-programmed response to hypercapnia can potentially impact their subsequent response to any sort of obstructive upper airway event. And this, you guys may be more familiar with it. So the concept of loop gain, which is more commonly described in the central sleep apnea and the pathogenesis of central sleep apnea, but I think control of breathing, we're beginning to understand, also plays a part when we think about somebody with obstructive sleep apnea. Then there's also the input from the pharyngeal sensory afferents and the pulmonary stress receptors, that essentially respond to changes in intrathoracic pressure that are really happening when somebody has a closed airway and they're trying to take these breaths. That generates a lot of pressure shifts, and in response to that, we can have changes in the upper airway tone. So, okay, so that was, sorry, I spent really long time on that slide. What are the common signs and symptoms and comorbidities of sleep apnea? I think everyone is familiar. Snoring, witness apneas, daytime fatigue. I think those are our three most commonly asked questions. But actually, interestingly enough, snoring and witness apneas, those two symptoms as predictive of having a positive sleep study, actually declines with age. So in our older patients, that may not be as useful. Also, in women, we tend to present with the atypical symptoms, so and/or are less likely to report snoring unless it's actively elicited. Or patients, or women, female patients may not experience any snoring at all, and rather can present with things like insomnia, depression, fatigue. And then I have on here some of the other sort of associated comorbidities or symptoms, and that's, I'm sure we're all familiar, the resistant hypertension, maybe pulmonary hypertension. I put a question mark here because this is heavily debated depending on who you talk to and what reference you're looking at. But typically, we do not associate significant pulmonary hypertension with just obstructive sleep apnea alone, unless the patient has extreme amounts of hypoxemia through the night, over the course of the night. It's more strongly associated with obesity, hypoventilation, which I also didn't really go into in this talk, but there's differentiating factors on the sleep side as well as blood gases. So just switching gears a little bit, a more practical slide. Obviously we can risk assess our patients and through taking a history and exam, but really the diagnosis of sleep apnea relies on the sleep study. So in general, there are two types of sleep studies. You guys are all familiar. There's the in-lab traditional attended polysomnography, which is the gold standard. And it essentially is the most comprehensive study, right? So it has EEG. It's going to give us limited, but there is an EKG, as well as signals on respiration. So there's airflow, oximetry, and obviously respiratory effort. So this is the patient goes overnight and then gets the whole shebang, and they love it. Just kidding. But the field has really moved more towards home testing for diagnosis, again, of OSA, uncomplicated obstructive sleep apnea, because it's more convenient. It's really done in their home environment, so that helps create a more real-world study. It's obviously the disadvantages are that it's unmonitored and there are fewer channels. There's a few different types of home studies, and I'll go into what we have here. But traditionally, it's for patients who you feel has a moderate to high probability of having OSA, and they don't have any of the other major comorbidities, which I'll show in a slide later. They can be referred for home testing. So for Mount Sinai logistics, or not just Mount Sinai, but in-lab study the in-lab studies basically have two CPT codes, but they represent three different studies, and you guys may already be familiar with this. But the 95810 is a diagnostic, so that means the patient is just getting a diagnostic study, there's really no intervention unless unexpectedly the patient has severe OSA, and then in that case there's like an emergency protocol that most sleep labs, including our own, has, in which a patient would be put on CPAP. For a titration study, so anything that involves any application of positive airway pressure or PAP, that's going to be your 95811. And then there are certain cases, like if you know, there's a lot of practical, I want to say factors, but it's really like annoyances in the field of sleep medicine because because of the influence of insurance and all these, Medicare and non-Medicare, they have like different guidelines for how old the sleep study is, etc. So in certain cases, you might want to try and do both in one night. In that case, you can order what's called a split night study, which means that part of it's going to be diagnostic, part of it's going to be therapeutic. But it's important to really specify like what are the criteria for splitting, and if you're not familiar with that, then you can sort of leave it to the discretion of the lab, which all the sleep orders that we get here are reviewed by either myself or Omar. So and then we looked at the chart and sort of correlated with what's the clinical documentation. But essentially, that's what a split night is. And unfortunately, Epic is really confusing because they both come up as so the diagnostic I think comes up as polysomnography 4 or more, so like over 4 years. And then the 95811s, whether it's split or just a pure titration, they all come up as polysomnography with CPAP.
How often do you find yourself like changing the protocol from what like we as the primary care providers or?
Generally, very infrequently. I would say the only we never actually make these changes because unfortunately it's just like we can't change the order, like the original provider has changed the order. So the most common situation that we encounter is actually someone who was ordered for a diagnostic who could have had a home study. That's the most common. But in those cases, because of like scheduling issues, the patient's already waited 3 months, like you don't want to sort of change the appointment. So in reality, it ends up not really being changed. But I think because there is such a wait time for any sort of in-lab study that, if we sort of more maximize the use of home studies, that could really help speed up the diagnostic process.
And logistically, if like we were to order a home study,
yeah,
what happens then?
Yeah, so I'll go into that.
Okay.
So home studies, and this is really confusing. So the 95807, I don't know if you guys are familiar, have seen that code, but I see it all the time. And it's basically if you type in sleep study, that comes up in Epic, and that's actually an invalid code. So we've been trying literally for a year to get Epic to take it out. Unfortunately, it's still there. But just so everyone's aware, 95807 is an invalid code. So the home studies are 2 types, and this is actually specific or at Sinai here we have 2 different CPT codes. So because there are 2 types of sleep studies. So that SOMT, and my next slide I'll show you actually. So there's 2 types of sleep studies. So the first one, the 95806, which was the original one, is a more comprehensive study, as you can see here. So it's a home sleep study, so the patient is applying all the sensors by themselves, but the SOMT does include a limited EEG. I tell everyone to take a selfie when they do a SOMT. It does have flow, and nasal cannula for flow monitoring. And it does have valves for respiratory effort. It has a snore channel, and it has EMG. So essentially, the only thing that's different here compared to a real in-lab study is it doesn't have that full EEG. So we technically can't stage sleep because we have only one lead. And it doesn't have the thermistor, which is like another way of monitoring airflow. But otherwise, it's a very comprehensive study. But as you can imagine, hard to put on. And obviously, there's an oximeter, which is not shown here. The new thing this is becoming very, very widespread in use in general, but it's called a watch pad, and that's going to be the 95800. You can see much simpler, literally, it's a watch plus this, plus 1 additional sensor, which I don't have pictured here, but it's just like a small thing that the patient sticks on the sternum. And both are validated for diagnosis of, again, OSA. So this is like just an example of what sleep apnea would look like. You guys have probably seen this at some point. But this is somebody with really classic, and this is a picture from the in-lab diagnostic study. So you have like your EEG channels up here. We have eye movements. There's chin tone. There's the nasal pressure or airflow, EKG, and then these are the leg EMGs. These are the respiratory effort belts. Snore channel, flow channel again, which is the same one here. But this top window is 30 seconds, and this lower half of the screen is 2 minutes. So we kind of look at these simultaneously when we review the sleep study. And then this is the thermistor channel. So there again, on the in-lab study, there's 2 measures of airflow. So somebody who has is a mouth breather will capture that on the in-lab, but say the person is just mouth breathing the whole night with the nasal cannula in at home, we might not be able to capture flow that way because there's no sensor actually in the mouth. There's oximetry and there's plethysmography, but essentially this is a very classic picture of someone with obstructive sleep apnea. And these events marked in red are long apneas in the presence of, there's initially some little effort, and you can clearly see there's effort here, as well as thoracoabdominal paradox associated with pretty significant desaturations, and this is non-REM. So this person, we know at baseline already non-REM has pretty significant sleep apnea. Wouldn't be surprised if they go even worse in REM. So this is like what we get on the PSG. My slides went out of order a little bit. But so when do we order? I think it might be missing a slide. I'm sorry. So I have a picture in here of what the watch pad looks like. But it's gone. Okay. So I put in this chart to sort of help as a, again, bird's eye view of when to order the in-lab diagnostic, when to order the SOMT, and when to order the watch pad. And I can maybe send this later on, but and I'm sorry it's very wordy, but essentially if you're suspecting moderate to severe OSA, it's uncomplicated. The patient, is a 35-year-old male, like no other comorbidities. That patient the fastest way to get him diagnosed is to get a watch pad, because this usually takes about 1 to 2 weeks or usually within the week we're scheduling patients, maybe maximum 2 weeks. And the report is, now we're trying to make a push to have all reports be back within 1 week of any study being done, but this certainly, getting to the study would be much faster. There are certain insurances though that do not cover the watch pad, and when they cover home studies, they're really covering the other one, the SOMT or the 95806, the more complicated one. That one's fine too. Again, the wait time is very similar for those two. In-lab, again, is an option, but will take much longer. And then basically everybody else who has a comorbidity, has advanced lung disease, which is probably a lot of the patients that we see here. If you're suspecting, certainly if you're suspecting hypoventilation, if there's any neuromuscular issue, if there's any suspicion for central sleep apnea, so the person has heart failure with a reduced ejection fraction or is on high dose opiates, probably an in-lab sleep study is better and or a consult. And then, if there's any suspicion for parasomnias or anything that the patient's reporting sort of behaviors at night, then again, the in-lab study would be best for those patients. Just to note, the watch pad cannot be used in patients who have a pacemaker who are AV paced. But if they're sort of pacemaker and they're not being asked to pace, then that's no problem. I hope these are my final slides, because I wish the watch pad really disappeared. I think it looks very different from the in-lab tracings. Okay, so any question?
Yeah. Do you happen to know what the copayment is for the patient for these home studies? Because I think we had tried one once and they got stuck with $300 bill. That if we had known about in advance of the patient, we would have said, no, thank you, I will wait 3 months and come in for my system.
It really is variable, depending on which insurance. I know there are some insurances that will, there's a copay regardless, and then I think some of the Medicaids don't even cover home studies, and or there's no copayment for the in-lab, and there's a copay for home setting. So I can't really say like as a general, but usually, with the exception of a few insurances aside, usually the copayment is comparable. So there's a copayment for an in-lab typically, as well as for home studies, unless the patient has like Medicare or just straight Medicaid, in which case those studies are usually covered fully. Yes. Yeah, I think, usually, so most of those patients get screened by the stop bank, and that actually is a population which it's one of the populations for which it's validated. For the most part, those patients can also get a home either a Santi or a watch pad. Unless, there's like really like he doesn't even report any snoring, then, in your mind you may question how likely this patient is really going to have sleep apnea, and that person maybe in the lab would be more appropriate just because it's more sensitive for the milder sleep apnea. Okay, so then moving on to, you've made the diagnosis of OSA with the sleep study. Now what do we do, right? So the traditional treatment options, obviously CPAP, I put on first because it's been around the longest. Again, there's CPAP versus AutoPAP. So CPAP is one continuous pressure, meaning the patient usually has had a titration study and the pressure setting is ordered based on that study, or more commonly now, again, for the uncomplicated, very straightforward OSAs, whether diagnosed in a home or an in-lab setting, most of those patients can be put on AutoPAP, and that means that I don't know if you guys can see that, but this is like the typical prescription that we would write for an AutoPAP, which is essentially we set that range almost always standard 4 to 20, and just let the machine do the adjustment on its own. And then when the patient comes back in follow-up, then we review the compliance and we can see whether if it's working, and that I would say that happens like 80% of the time. The AutoPAP is doing fine as long as the patient's using it. And we don't need to make any adjustments, and the patient just continues being on the auto setting. Or if there are any issues, there are certain adjustments that we can make afterwards to auto, or then we can send patients for an in-lab titration if we feel that's necessary. But so I think this might be relevant for your practice, because a lot of times you get the sleep study back and maybe the patient hasn't been to the sleep clinic yet, or has waited forever, and then we just like want to do something. We can actually, you or us can directly order the auto CPAP, and a lot of times, and this is sort of individual practice dependent. So I'll give you an example. I think in the pulmonary practice, if we have a patient who gets sent for a sleep study, whether or not they've had a sleep consult, we know that there are certain providers who are fine if they've already counseled the patient, hey, you might have sleep apnea, if we find this, okay, do you want to do CPAP? Yes. And then we can, after the sleep study is interpreted by one of the sleep providers, then we can just automatically order the auto CPAP. The problem with that, not problem, but like the only follow-up to that is that the patient eventually has to have either like needs to have someone review that download or be referred to a sleep clinic where we can review that download. So if you guys want it, I mean, depending on like what the preference is here, but in potentially we could have a system where like the sleep study is being ordered through this practice, and then counseling just preemptively letting the patient know, okay, if you're interested in CPAP, that's indicated in the order. We can order. Then at the same time, there's a sleep study sleep clinic referral. So then by the time the patients have had the sleep study, we can order the auto CPAP, and then they can come for their sleep follow-up or initial visit where we can review the treatment. That I think that's only one sort of way to do it, but I think a lot of the issues that we've come across is just the wait times both for sleep testing and for sleep clinic visits, and then the patient ends up like, it's from the day that he comes here to the day that he actually has everything completed, it's like 6 months later, which is really not appropriate or acceptable for good care. So that's something we could sort of brainstorm later, but just throwing it out there. And then in general, when we order CPAP, we typically prefer to use nasal pillows or a nasal mask. because not only is it usually more comfortable, but the pressure delivery is a little bit more efficient. So I put an example of like there's not a bazillion, but many different types of masks out there. These are nasal pillows. This is the Dreamwear. Many patients like this, and I think this is probably the least intrusive of the masks that are available on the market now. This unfortunately didn't protect well, but it's a nasal mask that essentially fits over the nose, and then the full face mask which fits over the nose and the mouth. If we sort of leave it up to the DME and we don't specify, a lot of times we found that they would just give patients a full face mask, which then, for, I wouldn't say for everyone, but for many people that really creates a lot of discomfort, and then that, really impacts their subsequent compliance. So there are requirements arbitrarily set by insurance and by Medicare. So the minimum 70% is, patients have to use a CPAP for at least 4 hours a day for 21 out of 30 days in a month. And they're only being checked in the first, we don't, tell patients this, but the compliance checking is really happening in the initial period after they've started CPAP. So Medicare, as well as I would say most other insurances, follow Medicare rules, and they require a follow-up in between 31 to 90 days after initiating PAP therapy for that initial compliance check, and they don't meet the 70%, then there needs to be documentation, they need to come back, and then they basically need to show that they're compliant within this period, otherwise they get a notice saying that their CPAP is going to be taken away.
Between all three, have there been studies kind of between all three masks saying that one is better than the other in keeping the airway patent overnight? Like is, the nasal pillow, while it's probably the most comfortable for patients, is it less effective than the full face mask?
Usually we actually, it's actually the reverse. So we think the nasal pillows and the nasal mask are more effective. Provided the patient is not a mouth breather, the patient's mouth is gaping open at night, then obviously the pressure can escape. But usually in that case, in an effort to avoid using the full face, we will put a chin strap on to keep the mouth closed or chin closed, mouth closed. What's interesting is with full face masks, they've actually done studies. So if you compare, and we see this sometimes on our in-lab tests as well, patients using a full face mask and we're at, pressure of 10, for example, which switched them over to nasal mask, and the 10 no longer needs to be 10, it can, he's therapeutic on 8. So we see that phenomenon a lot, and I think that may be related to there's hypotheses, but it's really not well described. But maybe there's there's actually backward pressure from the full face on the chin, and that's actually increasing the obstruction. But we definitely so when patients come in for titrations, and if there are cases where we're up to 18 or 20 of CPAP and they're on a full face, we really try to change them over to nasal and see if we can get that pressure lower. So. But there are going to be some patients who just like the full face mask, and if the download looks okay, that's fine, because I think out of all the factors, obviously getting the patient to use the CPAP is going to be most important in terms of therapeutic. So if they're otherwise doing well on a full face and the numbers look good, then there's no need to change. It's usually when we run into an issue or they're complaining of discomfort, think about discussing our mask change.
Question, sorry,
Yeah.
Is there a difference between the nasal mask and the nasal pillows as far as efficacy or preference?
A lot of times, and I'll go into this a little bit, sometimes people complain of a lot of nasal congestion, and that's why they can't use the nasal mask. But usually, if it's severe enough to cause that, then we usually suggest having them see ENT, because there's probably some turbinate hypertrophy or septal deviation that if we fix can actually improve their tolerance. But between the nasal, all other things aside, nasal pillows versus nasal masks, there's really no difference. Yeah. I would say, I guess I maybe tried all three, but nasal pillows are definitely the most comfortable and the least, having the least amount of stuff on the face. Okay. So we spent a lot of time talking about CPAP, but the elephant in the room is that despite how long CPAP has been around, how in theory we think it works, the reality is that a lot of patients just don't like it, and most there's been I can't say how many, but a lot of different interventions geared at trying to increase CPAP compliance, and we haven't really been able to raise that average compliance to greater than 50%, like sustained users of CPAP. So that obviously is very sad. But luckily, there are some other treatment options, and these are sorry, 2 more slides on this. But the most popular CPAP alternative now is going to be the oral appliance or the mandibular advancement device. And you can see it's a totally different concept. And like for people who, and I see this all the time, like, you know, when we see a patient in the office and they're like, I just cannot wear anything on my face. Like I can't imagine having to sleep with like anything. This becomes a much more attractive option. And this is essentially, the concept of this is, it usually comes in 2 pieces. Usually they're disconnected. Sometimes the 2 pieces have a connecting bar. And essentially the oral appliance or the mandibular advancement device does exactly that. It advances the mandible forward relative to the maxilla, and that like creates this tongue lift and opening of the airway. It's been recognized by the AASM, the American Academy of Sleep Medicine, as first line. It can be first line treatment in patients with mild to moderate OSA or severe OSA who's failed CPAP or can't tolerate CPAP. It's also indicated as a treatment for primary snoring. So you just have snoring, no sleep apnea by the AHI assessment, I'll say for now. Those patients may also benefit from an oral appliance. Downsides of it is that the insurance coverage is really variable, and most insurances do not cover it except for Medicare. So it requires a dental consultation. So there's a lot of sort of private dentists in the community, like EOS Sleep is a big one. But Dr. Basur here does it, and there's many dentists who are starting to do the oral appliance. There's actually, we do recommend a follow-up sleep study after the device is made. There's a period of adjustment so that it's advanced specific to the patient's tolerance and symptoms. And then we usually do a sleep study after that final position is reached just to document efficacy. There's really good long-term compliance data. Like the percentages are higher than 70%. So like way better than CPAP on paper. Patients do report that it's usually more comfortable. The most common complaint that we get is TMJ, like jaw issues, and some people really experience a lot of drooling that they don't like. But otherwise, it's generally well tolerated. There's also, you know, there's been comparisons, not many, but ongoing comparisons between CPAP and the oral appliance. Obviously, CPAP will lower the AHI much better than the oral appliance, but in terms of outcomes of quality of life, sleepiness, and maybe even blood pressure, the oral appliance is actually similar, has been shown to be similar. But again, these are really small observational studies. Okay. So that's usually my order of like sort of counseling the patients. We have CPAP and oral appliance, and we sort of do those equivalent. And then we go to the ENT arena, and basically we often send patients to ENT again if they have a lot of nasal complaints, because it has been shown. So if people get with a septum repair or a turbinate reduction, it does reduce snoring. It typically does not completely eliminate OSA, but it will improve the tolerance of nasal CPAP. So that's like the less invasive of the ENT interventions. There is upper airway surgery, and a lot of patients more and more patients are asking about, is there a surgical option? The traditional surgery, which I didn't put on here, but that was a UPPP. It really hasn't had long-term sort of efficacy. It's a very invasive surgery. So then, we've seen tons of patients. They had the UPPP in the 90s, and then they came back, and they still have moderate or severe OSA. But the one surgery that actually does work is the maxillary mandibular advancement. So like literal face forward. The 85% success, but it's really invasive. And I think this is done much more commonly in the pediatric world. But usually there's very few. We were talking to Dr. Lin the other day. I think he's had like 1 or 2 cases of adults undergoing the MMA procedure. What's more common now and growing is a hypoglossal nerve stimulator. So that's the Inspire, which is now up to 2nd generation. And essentially and this was the pivotal study that came out in 2014 in the New England Journal, that led to the FDA approval. It actually had been like sort of toyed with and played with for maybe like 7 years before that, but then I think after this study, the FDA finally approved it. So this was a trial, and they had very specific criteria for sleep apnea patients. So the BMI had to be less than 32. The AHI, they were targeting a moderate to severe category, so AHI between 20 and 50, and no evidence of the complete concentric collapse, which essentially is an integral part of the evaluation that someone needs to get to have the Inspire, which essentially they get a endoscopy using usually propofol, and we're looking for velopharyngeal collapse. And basically, the patients have to have anterior posterior collapse and not the concentric circular collapse in order to qualify for the nerve stimulator. And so in this trial, they actually saw a reduction in the AHI by 50% at 12 months. Just of note, though, the mean AHI to start was 32, and then it went down to about 15. So it wasn't like the sleep apnea was totally eliminated, but definitely improved, especially for the patients with the higher AHIs. And there was improvement in sleepiness as well as quality of life indicators. And so the typical pathway to get the Inspire or hypoglossal nerve stimulator at Sinai, Fred Lynn is the person who's sort of spearheading this. The process is the patient has to get a DICE if the drug-induced sleep endoscopy. If they have the correct sort of anatomical collapse, then they're referred for the implant, and the implant involves a generator that sits in the chest, and then there's a sensing lead that's placed in the intercostal muscle, and then there's the simulator lead, which goes to the extrusive branch of the hypoglossal nerve. And they basically really dissect out the nerve and only isolate that segment. Then the device isn't actually turned on until about a month later. And when the device is turned on, then the patients come back for an in-lab sleep study, and there's an actual titration. Usually the complication rate, both in that study as well as I think what Fred's described here, has been very low. I think he's not had to explant anybody. The major other than this routine surgical complications, I think one of the ones that he's had is just loss of taste, which obviously can be very distressing for patients. But apparently, in the time that happened, it slowly sort of came back over some period of time. So I think when we end up seeing the patients in the office, we sort of counsel them, and we really only go here if they've exhausted or clearly state that I don't want anything else other than I don't want CPAP, I don't want the oral appliance, I cannot lose weight. So we try not to jump straight to surgery, but it is an option. And I think the main hesitation for that is just because there's this study was in 2014, but there are newer there are newer versions and different models of the hypoglossal nerve stimulator coming out. So there's basically just need more data, or perhaps I'm just too conservative. Okay, and then some of the other more benign options. So positional therapy, positional OSA is definitely a very real thing. Some patients really are only supine and they don't have any sleep apnea on their side. So there's mechanical devices. I tell people tennis ball in the back of a t-shirt works. What the guy is wearing is called a Zoma pillow. But that can be purchased on the website. People can buy pillows on Amazon. But if cost is an issue, again, you can just be old school and use the tennis balls, and that seems to work as well. If you want to be more fancy, this is something that also I think was approved in 2016. It's called a night shift device, and essentially it's a little collar with a sensor that the patient wears on their neck, and it generates vibrations when it senses that the person is on their back. And it's actually been shown to really help with condition. Not the bad partner. Okay, and then obviously weight loss we always recommend. There's really not a linear relationship between weight and change in AHI, but in general, we start to see improvements in the AHI at 5 to 10% of weight loss from the baseline. So that's sort of generally where we try and target. Okay, sorry, feel like I may be running out of time, so I can go through the rest really quickly. Any questions before I go? Okay. So I just like the last couple of slides I threw in here because, this comes up a lot. Obviously, there's a lot of OSA comorbidities associated with sleep apnea and, cardiovascular, pulmonary, neurologic, endocrinology, and endocrine as well as quality of life. I think like a lot of patients come to us and ask, okay, like what does this mean for, and many patients are interested specifically for cardiovascular sort of outcomes, and that has been definitely the subject of a lot of studies, so I wanted to spend a little bit of time on that. But I also wanted to highlight, this is still in its baby stages, but there is emerging literature that there's association certainly between OSA and risk of stroke, as well as cognitive decline, which we sort of anecdotally know. A lot of patients complain of memory issues, but there's also data now that perhaps OSA, specifically REM OSA, is associated with an increased risk of Alzheimer's and early plaque deposition in the brain. So really busy slide, but essentially my takeaway point from saying this was, I think one of the most common questions that we get asked is like, if I use CPAP, what does this do for me? Will it reduce my risk of X, Y, and Z? Hypertension, I think is unfortunately one of the few outcomes that actually has a positive signal. So yes, CPAP use does reduce blood pressure to a modest degree in patients with sleep apnea. And just to note, most of these studies or essentially all of the studies that have been done really excluded patients who were really severe hypoxemia or sleepy. So these are all trials that were done in patients with moderate, at least moderate OSA, but who were non-sleepy. But this paper did show with good CPAP adherence, a small reduction in the systolic and diastolic blood pressures by about 3 to 4 millimeters of mercury. And then similarly, this trial actually didn't show any statistically significant reduction overall in the incidence of hypertension, but except for the small group of people who were actually good users, and that was arbitrarily traditionally defined as at least 4 hours of CPAP use, that actually did show some mild reduction in the composite endpoint of hypertension, cardiovascular event, or hospitalization. And then, contrary to what we would love to tell our patients, CPAP really does not help us, in the studies, does not help with weight loss. In fact, and this is a graph from a meta-analysis, in fact, has been associated with some mild weight gain. But the other sort of lifestyle interventions, and perhaps, I always try to sort of temper this by saying, with more energy, and then you just have a better quality of life. But like in papers that have actually looked at just weight itself, it has really not been directly associated with CPAP use. Okay. Essentially this is just saying that CPAP versus oxygen. Again, CPAP does help with blood pressure, but the next two studies I think are the most have been the most harrowing and has really thrown the sleep community for a loop, because so in 2016 this was a Ricasa study, and then followed by the SAVE trial. Essentially that was looking at reduction in other cardiovascular endpoints, so mortality, incidence of stroke, incidence of MI, needing revascularization, and it really didn't show. And so in patients essentially for secondary prevention, patients who were already diagnosed with coronary artery disease, CPAP in neither trial showed any improvement in those hard endpoints. Again, we can sort of argue about like the fact that it was a composite endpoint and there were some subgroup analysis that showed some signal, but all of us were sort of surprised to find that there really was no major significant reduction in the cardiovascular endpoints with CPAP use, except for, again, like in that subgroup of patients who were very adherent to CPAP. In the Ricasa study, there was maybe a signal that the more adherent users did have a mortality benefit. And then in the SAVE trial, and this is, I think, the most interesting, and it's going to be the motivation for now trials that are being designed. So it showed that specifically in women who were adherent to CPAP, there was potentially a lower risk of stroke. So I think this is sort of helping, reminding us to sort of rethink what we traditionally associate in terms of comorbidities with sleep apnea is really maybe not the coronary artery disease prevention, and perhaps there's more of a cerebrovascular benefit. And then there's sort of different hypotheses about what could explain these findings, but I won't go into that for the sake of time.
What is the significance when you look at these trials of that they're sleepy or not sleepy with apnea?
Yeah, that's like a big area of contention.
They're only looking at the not sleepy.
Yeah, all of the, and for like ethical reasons, people have just, and for safety concerns, like they've always excluded the patient. So perhaps, that's what we're really, I think the ending of my talk is essentially saying that, I think we need to really rethink how we've thought about sleep apnea, and maybe there's a different way, different types of patients that we need to study. So that is a really good question, but unfortunately it's unanswered. There's also the issue of compliance, and in most of these trials, compliance was super bad. So, that's the back and forth that happens at these conferences, and believers in CPAP versus non-believers, and that debate unfortunately is still going. I just want to put an aside in here. There is small but some positive data for OSA and AFib. So OSA is high prevalence in patients with atrial fibrillation, and also untreated OSA does seem to be potentially associated with recurrence of AFib after cardioversion. So a lot of our patients are now coming from cardiology, either pre, post, like as they're planning for their cardioversion. And then this one is just, I didn't want to make CPAP seem like it's a total fail, because that's not true. CPAP does actually improve, and this is consistent almost across all studies. Even in patients who are not at baseline sleepy, it does improve sort of the quality of life and other functioning, vitality, mood. So that's a very different, endpoint that is equally important, I think. Okay, and then I think this, we sort of went over that. That was a summary. This is the last slide, and I think this is the most exciting thing that's happening in sleep now, which is, again, this paradigm shift, and where we really want to move beyond just the AHI and defining what sleep apnea is, because really all of the data that we've accumulated in the past 15 to 20 years of sleep research, and it's really in its baby phases, but I think we're now beginning to see that the AHI, so your AHI is 30 or your AHI is 15, it's not enough to really capture the clinical heterogeneity of these patients. And so this new hot phrase, kind of like what we did with asthma, but this is the new thing in sleep, which is OSA phenotyping. So, and I couldn't state it better, so I just quoted Audrey Zinchuk from Yale, who was one of the first people to sort of describe this concept. So it's basically a category of patients with OSA distinguished from others by single or combination disease features in relation to clinically meaningful attributes such as symptom, response to therapy, health outcomes, quality of life, etc. And this is a really nice sort of picture of the different data levels and different factors that we may want to think about and study in the future. And I think hopefully as the new and literally as we speak, there's many different trials that are looking at different components of this. Hopefully as that new information comes in, we'll be able to really better understand and then better counsel our patients and give them a more complete picture of what's OSA other than what the AHI is. And that's it.
Thank you.
Thank you.